Hi everyone, my name is Zenithesa Gifta Nadrini. You can call me Tessa. I'm a lead community and partnership from Center for Indonesia Strategic Development Initiatives, or in short, CISDI. I noticed that the speaker usually introduce themselves with their ethnicity as well. So yeah, I'm a proud Padang Banjarmasin from Sumatra and Borneo Island, Indonesia. This is my very first time presenting in the conference, but not only presenting in the conference, but also attending the conference itself. So I'm both nervous and excited at the same time. I'm here with my friends, Tias, Primary Healthcare Program Manager, and Raka, Senior Communication Officer. Please feel free to drop any questions on the chat box and we could discuss it together if we still have time after the presentations. Okay, so I'm going to start the slides, please. Okay, thank you, Mikli. I'm going to start with the quote from Audrey Hepburn. You have two hands, one to help yourself, the second is to help others. Today, I will be presenting one of the insights from our program in CISDI under the title of Tackling COVID-19 Pandemic with Community-Led Initiatives and Primary Healthcare Strengthening. First of all, this presentation might be different from other sessions as it will not mention drug use, but will present to vulnerable groups and workers' rights, how community-based intervention is the solution to reduce harm caused by the pandemic in Indonesia. This is our first ever presentation in HRI conference, and we are very humbled to be here. Thank you so much, HRI, for broadening the topic so that we can join together in this conference. So, a little introduction of our organization. CISDI is a nonprofit organization that aims to contribute to the building of a healthy, equal, and just society. We are committed to advancing the development of the health sector through research, advocacy, and intervention. Our focus is on tobacco control advocacy, sugar, sweetened beverages advocacy, global health, and of course, primary healthcare strengthening, in which we will share to you today. So there's actually a dilemma from the existence of a COVID-19 pandemic in Indonesia. A, it is unknowingly scary, deadly, and tiring. But B, it brought the spotlight to the health discourse that was usually found exclusive here in Indonesia. It is a silver lining indeed, like everyone is suddenly aware of health protocols, becoming doctors in their own family and communities is a wake-up call for us. As you can see, Indonesia, Australia's closest and largest neighbor, is a country with 273.8 million people. And here you can see in the picture, there were two waves of COVID-19 cases spike, which was in late 2020 and middle 2021. After just a year of the first detected cases of COVID-19, which is in March 20 to March 2021, the government has reported over 1.5 million confirmed cases with more than 40,000 deaths. This places us the country with the highest number of infected people, confirmed deaths, and fatality rate in Southeast Asia. It is an award that we are not proud of, obviously. Among the cases, those who were the most vulnerable are older people. As of 15 March 2022, persons aged 60 and over make up 12% of the COVID-19 confirmed cases in Indonesia in total. Nearly half of deaths due to the COVID-19 have also happened to older people, making them among the most vulnerable groups in the pandemic. And furthermore, during the promotion of vaccination in 2021, the policy to protect vulnerable people was being questioned. So the solution that came on the pandemic for the Southeast Asia, as guided by the World Health Organization, is to emphasize on a stronger whole of society approach to prevent more loss of precious human and other resources. In Indonesia, looking at our national health system pyramid, we know that this is possible actually by maximizing the role of primary health care. Is in Indonesian. Yeah, you can see it here. You can maximize the role of primary health care as the base of the health facilities and also the backbone of the health system. But turns out, on the contrary, COVID-19 has exposed weakness of our national health system instead. The first weakness is that there is an overlapping policies between central and local governments that holds up effort to strengthen primary healthcare. One example is health data governance. In the context of the COVID, there is a disconnection of the health data that is not integrated between facilities, between areas as well. So our joint research with one organization of research called Puskapa found that there are still many vulnerable groups who have not received vaccination due to, first, not being detected, mainly elderly, people with disability, people with living with HIV, and also those who cannot access vaccination due to not being recorded because they didn't have any identity card, like a gender and sexual minorities. This poor health data governance makes it difficult for them to access primary healthcare services and thus deepens existing vulnerabilities. The second, since forever, the focus of development in Indonesian health services has always been for hospitals and not for primary healthcare. We can see that in the last 5 years, from 2016 until 2020, the number of primary healthcare posts, or we call it puskesmas, only grew 4.5% in 5 years, whereas the number of hospitals is increasing, grew by 19.7%. In addition, the budget for hospital development is actually 6 times bigger than primary healthcare facilities. This whole hospital-centric system makes primary health services unable to perform their best during the pandemic. The third weakness is that a report by the Medical Association in Indonesia revealed that more than 600 healthcare workers died because of COVID, and it is not just a number. This has put Indonesia in the first and the third place in the region and in the world, respectively, in terms of the COVID-19 fatality rate among healthcare workers. Moreover, healthcare workers experience burnout because of the decreasing number of active workers. They have to, shifting in order for them to deliver the attending to the patients, and with an extra additional burden, which is the stigma from the society. They were labeled as the spreader of the virus and disregarded by the community. True story, one of my friends nearly got kicked out from the house she rented just because she is a nurse. And in return, healthcare workers were not able to attend the patient needs and forced the patient to self-isolate without proper monitoring. The fourth is that there is a study with respondents from primary healthcare posts showed that there was a lack of personal protective equipment or PPEs for the healthcare workers. And last but not least, findings of the WHO and CISDI highlight the unmet need for basic health services. Health facilities reported the discontinuation of monitoring child health development, discontinue of immunizations, disruption in the distribution of vitamin A, and discontinue of antenatal care. As a result, the percentage of pregnant women who made it for ANC visit decreased in 2020 compared to 2019, I mean. And so it's the decreasing of delivery and postnatal care visits among newborn. So this was actually vital, as the impact will be undetected stunting and higher risk of chronic energy deficiency pregnancy. To put it simply, in short, Indonesia is simply not ready. So what do we do? Getting back to the root of the solution, those two, strengthening primary healthcare, is actually the key to tackle pandemic, be it COVID-19 or the future pandemic. As CISDI is the civil society organization that works not only through research and advocacy, but also to give implementations. We're trying to provide evidence for the government on what will happen if we put our focus on primary healthcare strengthening. We are trying to prove that primary healthcare strengthening could work during this pandemic. So this is the concept of primary healthcare from WHO. They put empower people and communities as an integral part of it. From this triangle concept, we developed the concept of strengthening primary healthcare post during the pandemic. Integrating in community to the health system aims to strengthen and protect the community itself. So the Indonesian government here points out 3 T's, which stands for testing, tracing, and treatment, including isolation and medication. That's our government introduction for us, guide for us to handle the COVID-19 pandemic, which you can see in the middle. And we at CISDI added another 2 T's, which are train for qualified human resources and T for teach for health promotion and competence. So it is all in this scheme, and vaccination along the way as well. So what we did is that we tried to put our focus, our piloting on the one province, which is the most populous province in Indonesia with a high number of COVID-19 infections, West Java. In 2021, we started with a program called PUSPA and continue in 2022 with the PAN Prima program or Prima program. So remember that one of the weaknesses and one of the challenges happening because of COVID-19 is the running out of healthcare workers, right? So yeah, we came with a solution, and here is what we did. We actually, during the pandemic, we discovered a strong existing modalities that could help us out handling health emergency, the health resources from the community itself. They are the community health workers, or in Indonesia, we call them kader kesehatan, who first live in the area, live in the community. Second, know their neighbors best. And the third, they have been keeping updates on the health status of the community regularly since like ever. They are usually, but not limited to, mothers in their 40s to 50s and have been working with local services for years. They are actually the strategic partners that we should collaborate with, and there are numerous of them. And that's exactly what we did. CISDI worked with more than 3,000 community health workers in coordination with more than 100 primary healthcare posts to train them for 2 things that non-medical personnel can do. But first of all, although community health workers exist, they actually are not prepared for an external shock like COVID-19 pandemic, maybe unlike other community healthcare workers in the developed countries, which I will mention later. Okay, so here's what we did with the community health workers in Indonesia. First, they were trained for community-based surveillance. They will find the neighbors who have influenza-like illness and drive them to get tested in primary healthcare posts. They actively trace their close contact as soon as they can. And in result, around 90% of patients trace at least 15 close contact in just 72 hours. This is something that is never performed before in the community. So this is one of the achievements. And they also monitor the self-isolated patients and visit their houses to deliver medicines and give food aid if needed. During the program, around 170 health students also volunteer to help out volunteering for tracing and as well as isolation, but through online chat or call. And community health workers also provide educations and campaigns for health protocols and vaccination, during which we include marginalized groups such as transgender, HIV sufferers, and people with disability in surveillance and health promotion. And together, reaching more than 700,000 individuals and 1,000 risky public places in just 6 months. And second, that we did with the community health workers, we trained them to accelerate vaccination for vulnerable groups, because we know that since there has been no consensus in Indonesia to the definition of vulnerable health groups, they were previously neglected. They successfully recorded the neighbors who are yet to get vaccinated with focus on vulnerable groups like elderly, people with disabilities, and marginalized groups. Then afterward inform to the healthcare workers and drive them to the primary healthcare posts with their own vehicles. In result, the data recorded more than 20,000 vulnerable groups, in which 4,000 of which want to receive COVID-19 vaccines. Other than vaccination, the community health workers help in the recovery of the non-communicable diseases and nutrition program that was interrupted by the pandemic. They did door-to-door visitation to record the number of pregnant women with high risk of pregnancies, children with stunting risk, and organized campaign to increase screening of hypertension and diabetes in the community. They usually did that before the pandemic in Posyandu Integrated Healthcare Center. But since it was disrupted by the pandemic, the community health workers are the one who revives it again. So these rangers of community health workers gives update daily as well to the healthcare workers so that everything is well documented. In the Prima program, we have an application in which up to 90% community health workers actively perform dashboard data input every month. So basically, the community health workers work like this. They find the people in the community, they report to the primary healthcare post or puskesmas. With gotong royong culture of Indonesian, or we call it mutual cooperation spirit, they did it wholeheartedly. So after we presented all that we do, all that we did to the West Java provincial government, they decided to continue the program, and now Puspa is managed independently by the government. So this is actually one of our biggest achievements in order for the government to adopt and to continue our program that we used to pilot before. So what do we learn from this actually? We know that in order to get things done, the community knows best. Community health workers are the strategic soldiers in facing future health emergency because first, they live close, they live around the corner. There are a lot of them, and they are trusted because the community already knows them and they are already trained. Unlike newcomer healthcare workers who happen to work there actually. Therefore, community health workers can be at the forefront of the community during any future health emergency. But here's the catch. In Indonesia, they were seen as humanitarian volunteers and thus did not receive proper incentives and training. Community health workers in some provinces get paid, while some not. It depends on the local government authorities actually. And they are not yet defined as a part of the health system. In our neighboring country, Thailand, their community health workers, or they call them village health volunteers or VHV, they are recognized as a part of the health system legally. They get some incentive legally, like payment and also training. But here in Indonesia, we still have it in this disarray and are not coordinated thoroughly. So what do we do? Our goal is actually to get the community health workers organized and recognized in the health system so that they are known to support health workers. Activities that we are now pursuing is that first, we continue our last year's intervention and deepening the competency of the community health workers. We're actually striving to do that now, and we currently working together with almost 100 puskesmas. We're developing related research and advocacy effort to better accommodate community health workers nationally. This also, the third one includes efforts on redrafting Indonesian health legislation that is currently being in the talk. So an organized and recognized community health workers is our proposal to the Ministry of Health. And in parallel, the communications team also tried to introduce the community health workers to the public. We are trying to let them know by making a short documentary film. We call the film titled Dari Rumah ke Rumah. We are currently on a roadshow, and we also held exhibitions in collaboration with local critical photography collective called Academy. Because we know that although, like I said before, the number of community health workers in Indonesia is big, but not everyone knows and recognizes them. There is one of the quotes from our community health workers. She said that, I did not know that there are certain people with vulnerabilities around me who need my help to access healthcare. I've learned a lot by being a Prima community health workers, how to provide access to vulnerable people. So this is one of the picture and the testimony from the community health workers that work with us. So to close, I would like to quote Helen Keller, alone we can do so little, together we can do so much. That's my presentation. Thank you and hope you enjoy my presentation. Glad to share our experience with you guys. Let's connect. I actually put my email there, and also CISDI's social media, Instagram, TikTok, website, Twitter, and as well a YouTube channel. So if you guys want to connect with me. Yeah, so that's the presentation from me. So we actually have 10 minutes left. If there is anyone who wants to give comments or questions. Or maybe if you guys have any experience that you would like to share with us, and then maybe we can learn together, you can drop on the chat as well. Oh, I actually have my friends here, Raka and Tias. Do you guys want to add something? Oh, yeah. Hi, Aaron. Okay. Yeah, so the news. What news? Do you care to elaborate more, Aaron? Oh, yeah. Mhm. Yeah, thank you, Aaron. So, Aaron said that he saw the news about the healthcare workers dying in Indonesia during COVID-19. Yeah, that's one of the word that we are not proud of. Has the community recovered in some way? Um, we can say that now currently there is a we can say that there is actually a nice way of saying it that we are currently reviving from the COVID-19 pandemic. So we are not, but the cases of COVID-19 is actually increasing right now currently. So we have to put our mask on again, but we are reviving. So we are striving to do better now. So I think that's what I can tell you, that currently Indonesia is reviving from the COVID-19 pandemic. And Raka and Tia, do you want to add something to the Aaron's questions? Has the committee recovered in some way?
I think to add what you just said, Tessa. I think the community, the health system is not only reviving, as Tessa mentioned before. We have pivoting from the actions against COVID to revitalizing for example, the programs in nutrition, programs in non-communicable diseases, and other health programs. But also, after we've learned in Indonesia, after we've learned for the past 3 years about how the community itself is the resources of health, in terms of for example, the community health workers came from the community and then give back to the community. I think that has been passed through to these days nowadays, in 2023, where community health workers, as Tessa mentioned as well in the presentation, they became almost integrating to the health system, although it's not fully integrated yet. We're still working on it to advocate it to the national health system. But we can see that the community health workers becoming more be seen. I mean, they've becoming coming to the surface, where people can see, oh, there's community health workers. They are able to help the health system. They provide health promotion and prevention to the community, and so on. I think that's what I can add, Tessa.
Yeah.
Thank you.
Thank you so much, Tias, for the additional comments on it. Yeah, there's actually one question here from Kate Margits. If Mikli can pop it up on the questions as well. Were there any concerns from community about the privacy or engagement if community health workers visit their neighbors, I guess? So if I if I read it correctly, this is actually one of the what do you call it, like a challenge for the community health workers, is that because they're actually known by the society, but not everyone knows what they're doing. So when they visit from door to door, they can first maybe get accepted by the family, but second, maybe they will be disregarded by the family. Like some of the families just put their door closed if any community health workers coming. So that's actually a challenge for us, because what I've been saying before, although they are known by specific communities, but they are seen as someone who usually come to the places and maybe asking for money or something like that, but they are not like that, right? So that's what we've been doing. We're trying to tell the public, let them know that there is this professions called community health workers, and that's something we've been pursuing on. So that's what happened with them. So there's actually a stigma as well for them, attaching to them, especially I've been in a discussion with one of the community health workers. So so she actually compared coming to the society, coming from the middle age, what do you call it? Kalau apa sih, gengs? Kalau apa? Sorry for speaking Indonesian. Apa yang uang kalau kaya sama yang di bawah rendah?
Disparities.
Yeah.
There's
So
a gap.
yeah, so for those who coming from the low middle income families, they actually accepted the community health workers. But if they're coming from the high income families, they usually, put the closed door for the community health workers, because they didn't know that they are there to trying to help. So that's the challenge of community health workers that I've known. So yeah. So wondering if they will be more or less likely to disclose drug use and other thing. We actually didn't really know whether community health workers have any experience, Kate, for the drug use in the community. But yeah, I guess that's one of the challenge as well. If generally they will be disregarded by the community if they are not well known by them. So yeah, maybe do you
Maybe
want to add?
Tessa,
Mhm.
yeah, please, Raka, if you want to add,
Yeah.
go ahead.
You first. Yes.
Okay. Thank you, Tessa. Yeah, thank you, Kate, for the wonderful question. In Indonesia, as Tessa mentioned previously, the practice of community health workers providing or dispensing drugs it's not practically conducted in Indonesia. But we have a certain law that regulate for especially for community health workers working in the remote areas, that they can dispense drugs for malaria treatment, but they do not diagnose the patient. So after they conduct the test, for example, they have to report back. This is the common practice where community health workers then report back to the health workers in the primary cares, and then after this is malaria, you give treatment number A, for example, and then they can give the drugs, and then they monitor the drugs to the people who, or the patient who got the disease. However, it's not regulated yet for other diseases such as tuberculosis, malaria, or what we have experienced in nutrition problem and non-communicable diseases. The community health workers do not have, up until now, we're still working on how to make the optimal use of their being present in the community. It is a very, yeah, they have limited movement, or they have limited scope of work in the community at the moment, which we realize it is an opportunity to develop or to create a task shifting mechanism from the health workers to the community health workers themselves. I think that's how we can talk about the community health workers. I hope it answered your question, Kate. If Raka wants to add some more,
I
go
want
ahead.
to add some more about the question from Aaron and also Kate. After the COVID, there are still many communities in Indonesia, actually communities from vulnerable group who still feel the post effect of the COVID, such economic struggle and also the struggle to access to the health service. This due to the health system in Indonesia, which is still not ready to face a pandemic, because our government needs to make a policy that can handle this problem in the future. And actually, Kate, in Indonesia, still has a fairly high stigma against people who use drug, because there's a moral belief in our people is still quite high in Indonesia, and it takes time to educate the public. But at least in Indonesia, the health worker, maybe some of health worker are open space to the community to help people who use drug, which is in my area. There's a primary health care who collaborate with the community, people who use drug, to do some approach and to the to this health service, such as opioid service and syringe modeling
Si-
service
Mm,
for people who use drug like that.
mm, mm, mm. Thank you, Raka, for additional comment. So yeah, to close, I think there's a question from Amanda as well. Great presentation of the COVID-19. What issues will the community health workers be focusing on? So in with CISDI, like I think Tias has mentioned before as well, right? We continue with the program of reviving the health services for local health services for and nutrition and non-communicable diseases screening, so that more and more people will be screened for hypertension and diabetes as well. So that's what we've been focusing on. But there is any additional from Tia or Raka, if you want to add, what will happen? What issues will the community health workers be focusing on?
Mhm. Yeah, I think just to add a little bit information from what you just said, Tessa, we still want to focus on the end beneficiaries. We want to focus on still for the vulnerable groups. But now after the vaccination coverage has accelerated so much in the past years, we want to go ahead to the more programs that have more vulnerable people as their beneficiaries. For example, a nutrition problem that Tessa has mentioned before, and then non-communicable diseases. But when we talk about these vulnerable people, we don't only treat them for their diseases. For example, they have stunting or they have wasted condition or so on. But we also want to see from the social determinants of the health issues. So we want to develop our program more where we can also as Tessa mentioned before, for example, if the family is in a poor condition or they don't have a daily income for their household, how we can manage that for further prevention of other health issues, for example, something like that. So this is how we want to reduce the possibility of having other health impacts in the future for these vulnerable people.
Mm.
I think that's what we can add.
Yeah, and
Tessa, thank you.
maybe if I can add as well. So putting it back together, all of the presentation. So we want to create a system. We want to let the community health workers be inputted into the health system itself, so that if there is any pandemic that happen in the future, they are well prepared to face this pandemic. Because as we see in the Europe the developed country, like in Europe and in Thailand, in India, in Asia, they actually prepare their community health workers for all of the possibilities of health, because they included healthcare community health workers into their health systems. So they are recognized as the part of the health workers supporters. But now, because we are not like that in Indonesia, we are trying to provide them so that they will be the rangers that will happen maybe for the future pandemic, so that they can handle the future pandemic better. So after the COVID-19, maybe there will be another pandemic, we don't know, but we are trying to make them stronger, make the community health workers stronger, and be recognized legally in Indonesia into the health system, so that they can do, they can get incentive and training regularly that will be organized by the government. Yeah, that's. I think that will also the additional comments to your questions, Amanda. Hopefully, it will help.
I want to add a short answer for Amanda. Yes, our advocacy work are ready to push the health bill in Indonesia. One thing of we are pushing is the expansion of the definition of the vulnerable group in Indonesia. So so the advocacy is target to be no one left behind. Expect especially for a vulnerable group to face the next pandemic in Indonesia.
Okay. Yeah, that's what we've been pursuing on to the Minister of Health as well, right, Raka? Yeah. Thank you. Okay, I think that's all of the question, and we actually sorry, Mikli, we passed the time. It's 36 minutes. Thank you, everyone. Hope you enjoy our session, and maybe we can connect together in the future. And see you later. Thank you so much for having us together. Thank you, Mikli, for accommodating these sessions. Thank you.